Hello, everyone. Thank you for being here. It's a pleasure and a privilege to start our first collaboration between Diagnexia and the Egyptian Committee for Pathology Training, which will be a series of webinars, monthly webinars, addressing an optimal approach to biopsies from different organs and organ systems. I'm Mona El-Bahrawi. I'm Professor of Pathology at University of Alexandria, Egypt and Imperial College London. And I'm joined today by Professor Runjan Chetty, who is the Chief Medical Officer for Diagnexia, who is not only here today to see the launch of this new initiative, but also to deliver the first talk, which is the approach to an esophageal biopsy. It's a very difficult task to introduce Professor Chetty, because to do that and do it correctly, I will need to eat into a lot of the precious hour during which he will share his vast knowledge with you. Because Professor Chetty over the years has really added so much to the discipline of pathology and led pathology, academia and service in many world-class institutions across the globe, from South Africa, Scotland, England and Canada. And in addition, he's currently now leading the work at Diagnexia. One of the things that I find most impressive when I work and talk to Professor Chetty is his passion to giving and to teaching, and the immense joy he finds from sharing his knowledge. Runjan, it's a pleasure to have you today, and thank you very much for supporting the launch of this initiative and for giving the first talk.
Thank you very much, Mona, for that very generous introduction. Apologies, my camera is not engaged. We had a few technical issues, so I apologize for that. I'd like to also thank you all for attending. Diagnexia is a company that has outreach and education very much as a core fundamental value and something that we are very keen on fostering. So doing this series for the Egyptian Training Program in Pathology really fits in quite nicely with our entire remit. We're very delighted to support it. And in addition, we have several other educational offerings, and you can contact Ava Carr, and I'll give you her email address later, to register for other events. So the first talk is on the approach to an esophageal biopsy. And I think starting at the top of the gastrointestinal tract is really pertinent. And remember, the esophagus is a very important organ and is subjected to not only biopsies, but also various forms of resection. For today, I'm going to restrict my talk to the mainly to biopsy material, but I will make reference to the other types of specimens you can get. So I intend doing the talk in the next 50 minutes or so in 3 phases. The first part is to emphasize the normal esophagus, its gross anatomy, the important anatomic divisions, and then going into the histology and the histologic anatomy, if you will. And then I just want to dwell a little bit on the esophagogastric junction, because I think this is a critical landmark that we use in esophageal biopsy interpretation. In the second part, I will then talk about my diagnostic approach to esophageal biopsy, which I've done for the last 30 years, what types of specimens you get, the systematic evaluation when you're confronted by an esophageal biopsy, and then I'll try and highlight some of the key diagnostic features. Remember, there's a wide remit of pathology that we get in the esophagus, so I can't, in this 50-minute talk, discuss all of them. I'll try and highlight some of the major ones, and I've divided them into inflammatory, metaplastic, neoplastic, and then other important pathologies that you will see in the course of your career. So let's just start off with the nice basic anatomy. I think anatomy is really pivotal to pathology, anatomic pathology. The esophagus is 25 centimeters in length in adults. I'm not going to talk about pediatric pathology today. It starts off at the lower border of the cricoid cartilage at C6, the vertebral level, and extends all the way down to the esophagogastric junction. It's divided into three anatomic regions: the cervical esophagus, which is at its beginning, C6, to the thoracic inlet, spans about 5 centimeters and is interposed between the trachea anteriorly and the vertebral column posteriorly. And then it descends into the thoracic esophagus, which in turn is divided into upper, middle, and lower thirds, and extends for the largest part of the length of the esophagus, about 16 centimeters. And then once it hits the diaphragm and goes through the diaphragm, you're into the realm of the abdominal esophagus. And this is the part of the esophagus that really is below the diaphragm and is about 4 centimeters. This varies a little, and it terminates at the gastroesophageal junction, so where the esophagus meets the stomach. Now, I just want to clear up two things here. One is the esophagogastric junction, oftentimes surgically, so the surgeons define it as the muscular part of the OG junction, and that is where the esophagus hits the diaphragm, and that is regarded as the sort of surgical or muscular part. It's a band. It's not truly a sphincter, but it functions as a sphincter. It is a band of muscle that spans about 3 centimeters. Now, what we as pathologists are most interested really is in the mucosal esophagogastric junction, or otherwise known as the Z line or the squamo-columnar junction. And this can be and coincide with the muscular junction, or it could be a centimeter or two above or a centimeter or two below. But the most important measurement that we as pathologists need to know, and what the endoscopists do, is they measure it from the incisor teeth. And in general, on average, it's 36 centimeters from the incisor teeth. So when they do the endoscopy, they take the measurement from the incisor teeth, and therefore you can now know exactly at what level they've taken the biopsies. And most endoscopists will always tell you biopsy at 25 centimeters, 30 centimeters, and give you the intervals and exactly map it out. So you have a reference point now as to where in the esophagus the biopsy has been taken, and therefore you know exactly what to expect depending on where it is. And you'll know that because the Z line is clearly where the squamo-columnar junction is. So you will see squamous mucosa meeting columnar mucosa. And so dependent on where the distance is, you will know where you are. And as I said, this is normally located at or within a centimeter or two of the muscular OG junction. But once you have the measurement from the incisor teeth, you can then calibrate exactly where you are. Just be aware that there are some normal anatomic histologic variants where you have tongues of gastric mucosa that do extend up normally into the lower esophagus. Just be aware of that. And sometimes cardiac mucosa, gastric cardiac mucosa, can be present in the distal centimeter or two of the esophagus as a heterotopic phenomenon. So just be aware of that. So again, you're very dependent on the clinical information here, and sometimes you can make an erroneous diagnosis of Barrett's esophagus, which we'll come to later on, purely because we haven't taken into account the normal variants, or you have not got enough endoscopic information. So why are we obsessed about the esophagogastric junction or the squamo-columnar junction? Well, this is where the action is in esophageal pathology. Barrett's esophagus, a really important diagnostic entity that we get most of the time as a result of esophageal biopsies. Adenocarcinomas, so cancers that are gland producing, often occur at the junction. And reflux esophagitis, which is, again, a very frequently encountered disease entity, occurs in this particular region and is always biopsied. So for those three disease entities, the squamo-columnar junction or the esophagogastric junction assumes tremendous importance diagnostically. So what about the histology? And just to refresh your memories, we've all done this in medical school, but it's always good to know your histology well and what normal is meant to look like before you can appreciate what abnormal is. So it's made up of a mucosa. Sitting underneath that is a submucosa. Beneath that is the thick muscle band, the muscularis propria. And the outside layer, depending on exactly where it is either the adventitia or the serosa. So the typical 4 layers that you see in the gastrointestinal tract. The esophagus is made up of squamous epithelium, and I'll demonstrate this in a minute, which is 15 to 20 cell layers thick. It's divided into a basal layer, the layer above that, which is parabasal, leading into the spinous and the superficial layer. And that sits on a scaffolding or framework called the lamina propria, which is the loose connective tissue replete with vessels, lymphatics, scattered inflammatory cells, nerves, etc. The submucosa is more dense connective tissue with submucosal glands, blood vessels, lymphatics, and nerve plexuses. So it's more substantive nervous structures seen here. The deep muscle layer, the muscularis propria, again, inner circular and outer longitudinal, extends all the way through the gastrointestinal tract. But something just to remember here, in the upper 1/3, so the first 8 centimeters or so of the esophagus, it's made up of skeletal muscle. And then after that, it's made up of the typical smooth muscle. So if you get a proximal esophageal biopsy and you see skeletal muscle, don't be alarmed. It is normal. So they haven't perforated and gone into the strap muscles of the neck or anything like that. So it's very important to remember that the upper third has skeletal muscle there. The most outer layer in the upper and middle third of the esophagus is called adventitia, and the lower esophagus is simply called the serosa purely because it's got a mesothelial lining. So once you see mesothelial cells subtending the most outer layer of the esophagus, we call that the serosa, and that's because it is a serosal surface. Okay, and here we are, just to highlight the different layers. So the most superficial, obviously, is the mucosa, and the mucosa is then has a very, very distinct basal layer, as you can see, and that sits atop a lamina propria, which is this loose connective tissue with a few scattered blood vessels and inflammatory cells. And then deep to that is the submucosa, which has submucosal glands and more substantial vessels, nerves, etc. And then the deep muscle is the muscularis propria with the inner circular and outer longitudinal, as you can see. And this happens to be from the lower esophagus and therefore middle and lower. So this is an adventitial layer. We don't have any mesothelial cells here to call it a serosa. So those are the 4 areas, and you can contextualize it. Now, this is obviously, I've selected this picture just to show you that orientation isn't always ideal. And sometimes if it's obliquely sectioned, this muscularis mucosae can appear a lot more thicker and prominent than it is actually. And sometimes it can be quite thin and very slender and quite difficult to identify sometimes. So this is from an optimally oriented resection. But in biopsies, you generally will not get anything deeper than the muscularis mucosa. In fact, you'll just get 1 or 2 fibers of it. And that's purely because it is a superficial biopsy. But I just thought I'd show you this just to orientate. Okay, so what does normal esophageal squamous epithelium look like? I said, you've got the basal layer. And again, orientation here is really important. In most instances, when you get fragments of the squamous mucosa taken in an esophageal biopsy, they are not well oriented. Remember, they are in 3 dimensions. And if you've got 3 or 4 fragments, you'll never get all of them ideally sectioned. In many ways, we should be placing this in a sponge and have ideal orientation, but it is very difficult. So therefore, just remember and bear in mind, if you have an oblique section, the basal layer may not be nice and uniform and well delineated as I'm demonstrating here with the cursor. As we get it a little bit more obliquely, you can see it's becoming a bit thicker and appears a bit more prominent here as opposed to here. And don't then therefore overcall dysplasia. So what is, and I'll mention dysplasia in a minute. So just be aware that you have oblique sections and you have these tongues of the lamina propria extending up between the papillae, squamous papillae. And if you have it sitting high up in the epithelium, you definitely know that this is a tangential section. Ideally, they should be where they are down here and not extending up here. So just remember that. You've got the suprabasal layer or parabasal layer made up again of squamous cells, the spinous layer, and you'll notice that you've got prominent nuclei here, and the cells look quite reactive and active. And as you ascend and go to the surface, the nuclei become less frequent, and there is this phenomenon of flattening. So this flattened mucosa here, where the nuclei are now flattened and elongated, as you can see very nicely here, as opposed to the nice round juicy nuclei at the base, this is the normal maturation process. And when you see normal maturation process and flattened nuclei at the surface, you know that is benign and that is non-dysplastic. Okay, so just to tell you what types of biopsies you can get from the material you can get from the esophagus. Endoscopic biopsies clearly are the most common because the esophagus is amenable to endoscopy, and using standard forceps, the fragments that are generated are 2 to 4 millimeters in size, and therein lies also an issue. If you get very superficial, tiny fragments, it's quite hard to make a diagnosis, and therefore, as a diagnostician, you've got to keep your wits about you and maximize the potential of these small fragments. You generally should do multiple levels of the tissue that you get, and the endoscopist should do biopsies at multiple levels as well, depending on the pathology that they are seeing and the disease entity that they're doing the endoscopy for. So they should do it at separate levels, and they should separate these biopsies. So those that are from 25 centimeters should be in a pot on its own. Those from 27 in a pot on its own. If they put it all together and have biopsied from multiple areas, there's a problem, because if you find an abnormal fragment, you do not know where it's coming from, and you must reflect this in your report. Okay, other specimens that are now reasonably frequently seen are endoscopic mucosal resection, and this is again an advance in the surgical treatment of esophageal pathology, and we'll see these a lot more, and they are mini kind of resections which are taken for more superficial rather than deep penetrating lesions, but however they are substantial enough for you to assess the depth, and when you get these they should be pinned out, and you should ink and take great care when grossing these specimens. Similarly, endoscopic submucosal dissections, which are more substantial than the preceding EMRs, similar sort of approach to it. And then when you get full esophagectomy specimens, clearly you will have a standard operating grossing protocol and pin them out, take the necessary blocks and resection margins, ink, etc. And your reporting is guided by whichever reporting guidelines you use, whether it's the College of American Pathologists or the Royal College of Pathologists, or whatever national guidelines are in play. Okay, so what about approaching these biopsies? So great, you've got a tray of slides that have come in marked as an esophagus biopsy. What do you do? Of course, you start to assess the tissue. You assess whether it's adequate. So remember, I said these biopsies can be very tiny, and if the endoscopist has not done a good job of getting them with the small forceps, they may not be adequate. So confirm the presence of mucosa for starters. Identify if you've got the full representation as well. Sometimes you just get slivers off the top, and there's very little you can do with it. Do not overextend yourself. Do not force a diagnosis, and don't feel pressured by the clinician. You do your due diligence in trying to do the best job for the patient, not for the surgeon. The next is to identify the epithelial types that are present. Clearly, if you've got squamous mucosa in where it should be, so up to 25 centimeters. If you've got columnar mucosa at 25 centimeters, you know that that should not be there. And sometimes you get a mixture of both. And that's why you need to know whether the biopsy is from a particular distance from the incisor teeth. So that is critical. So if you have got these two types of epithelium, you then have to interpret them in the context of the distance from the incisor teeth. And now this is the most important thing actually we can do, is to evaluate the histological features that we presented with by the slide. Now, personally, I'm a top to bottom pathologist. I always start at the surface on anything that I look at that is of a mucosal lining and work my way down. And I go layer by layer. Now, when you're confronted with a biopsy with an obvious pathological entity in it, a large tumor or something that really catches your eye, we tend to jump towards that and forget the rest and say, oh yes, there's an obvious cancer here, end of story. but look in the adjacent mucosa. And if you have a systematic approach and you take it level by level, you will not miss incidental pathology. And that's something that you will see quite frequently in your practice, that you get 1 and 2 and 3. Multiple pathologies often coexist, either incidentally or related to the major pathology. So don't get distracted. Keep a note of, yes, there's an obvious cancer there, but stick to your routine, top to bottom, layer by layer. And you look for particular features that you'll identify. You look at the surface. Is there maturation? As you come down, is there hyperplasia? Is there pupillary elongation? Is there dysplasia? Is there squamous mucosa? Is it columnar? So you go through all these features in a checklist manner. Assess the inflammation at all levels as well. So you can get epithelial inflammatory cells within the epithelium, intraepithelial lymphocytes, intraepithelial eosinophils. And generally, when it comes to eosinophils, I count them, okay? And you'll see why. Lymphocytes, not so much. There is an entity called lymphocytic esophagitis. It is somewhat difficult to diagnose from a pathologist's point of view. You need the clinical information here. And you can count it and quote it per high power field. There are no real hard and fast diagnostic criteria for lymphocytic esophagitis, but it is worth noting that lymphocytic esophagitis can coexist, for instance, with celiac disease, which is impacting the duodenum. So remember, look at the lymphocytes, and oftentimes you get a normal lymphocyte component within the squamous epithelium. But if you get eosinophils to any significant degree, count them. Then you look for specific features that make a diagnosis. Well, are there organisms there? Is there ulceration? What do the submucosal glands look like? Is there fibrosis? So you start to piece it all together as you go layer by layer. And remember, some of these histological components, inflammatory cells, organisms, ulceration, can exist in the different layers as well. You've got deep ulceration, which can go right down to the submucosa in some instances. Now, the most critical thing that I can advise is always correlate with the clinical information. And if you don't have it on the pathology request form and you have no access to electronic patient records from the hospital, phone the clinician, email the clinician. Otherwise, you issue a report with caveats. Now, I don't personally advocate defensive reporting where the pathologist says it could be this or it could be that, and you can't make up your mind. At the end of the day, you're not helping the patient. Try your best to get the information you need from the clinician to make a diagnosis or suggest a diagnosis. So very important things are the endoscopic findings. Where did they take the biopsy from? What did they see? What do they favor? The patient symptoms, medication. I can't emphasize the importance of medication history in not just esophageal pathology, but in the entire gastrointestinal tract, because everyone is taking drugs these days or is on some form of medication. Also very important to know what the previous biopsy showed or the previous diagnosis, whether it was in your hospital or in another place. This is also very informative in making and shaping your own diagnosis. So try and get as much information about the case as possible. Okay, so let's move into some of the pathologic entities now. So reflux esophagitis, gastroesophageal reflux disease. And this is kind of obvious, and I think everyone knows this. This is just reflux of gastric contents into the esophagus because of an incompetent sphincteric action. And the patient manifests this classically with so-called heartburn, especially after meals or lying flat. And depending on the severity, you get, the epigastric pain may simulate even a myocardial infarct. But then you get dysphagia, dynophagia, and then if you get fibrosis, you get food getting stuck, etc. So they do at least provide this minimum information. And so you know what you're dealing with. Endoscopy is the investigation of choice, and esophago, gastric, duodenum, those three go together. So invariably, you'll get an esophagus biopsy with a gastric biopsy with a duodenal biopsy. And this is quite useful because it correlates with disease in all three sites, which may be related, especially if it's acid related, or even, as I mentioned earlier on, if there is coexistent celiac disease, for instance, you can then compare the lymphocyte count in the esophagus with that in the duodenum intraepithelially. Now here's some pictures of what reflux esophagitis looks like under the endoscope, and you can see clearly that the mucosa, which should be like this nice salmon pink appearance, is really red and angry and inflamed. And when they put the scope down, they can see gastric contents refluxing back from the stomach up into the esophagus. And here we've got more with ulceration, and you've got exudate here, and you can see it's a little bit bumpy. And that is this granulation tissue that is responding to the areas of ulceration, so-called proud flesh appearance. And then here, in contrast, you'll see there's great narrowing of the orifice. And here you've got redundant mucosa, you've got fibrosis. And again, it looks really irregular and not very happy. And this one here is also quite extensive. You've got necrotic tissue there and fibrosis and ulceration. Fibrous tissue appears very pale and white. So you can see that this is very fibrotic here in contrast to these two. So these are just differing examples of endoscopic pictures of differing severity of reflux esophagitis. So what should you be looking at? Okay, so again, it depends on the type of epithelium that you've got. So let's just separate it and say, right, if you've got squamous epithelium, what will happen is that the basal layer will start to react. Okay, so remember, the basal layer of the squamous epithelium in the esophagus is the generative epithelium, and it normally turns over in 10 to 12 days, and cells go from the base all the way up to the surface and mature and are shed by anoikis, this phenomenon of shedding. And under normal circumstances, the basal layer is, as I demonstrated to you in the histological slide, it is a nice uniform layer. But once it starts to get thickened, again, when optimally oriented, you will see this reactive change that is accelerated now because the basal layer is irritated by the gastric contents. The epithelium starts to react. You now get papillary elongation. So those rete pegs that are analogous to what you see in the skin, those elongations now start to become prominent. And then because there's inflammation, you'll get increase in edema within the mucosa, the squamous mucosa, spongiosis of the skin, the same sort of phenomenon. And again, depending on the severity, the surface will ulcerate. And if it hasn't ulcerated, one of my mentors in Australia taught me this term, because the acid is very acidic, it scalds the delicate squamous mucosa. So it has this very eosinophilic appearance. It's like something that has burned the squamous epithelium. Not quite ulcerated it, but burned it. It's a step before. And you'll see that the cells lose the nuclei. They become very pink and amorphous, almost ghost-like, like it's been scalded by acid, which it has. Okay, then the next component is to look at neutrophils and eosinophils. Again, if there's ulceration, you will find a mixture of both. You will even find macrophages, so you report in context. Now, you will find eosinophils in reflux esophagitis, and they usually, and that's why I say count them, usually less than 5 per high power field. Once they start to get more than 5, then you start to entertain another diagnosis, which I will do in a second, and that's eosinophilic esophagitis, where that diagnosis is not only dependent on the count, but also the clinical information, and we'll come to that. If it's very severe reflux, that inflammation can go all the way through the mucosa down into the lamina propria. And the lamina propria is also inflamed in a similar fashion to the epithelium. As I said, in very severe cases, you can get a complete breach of the esophageal mucosa with ulceration extending all the way down. And the reaction is as a normal inflammatory reaction where the vessels become prominent together with inflammation. So it's a normal sort of almost exaggerated physiological response. Okay, so some of the diagnostic, well, I'll call them pearls or pitfalls to be aware of, is that the histology may be normal, even if the endoscopist shows or thinks it's esophagitis. Now, whether the esophagitis is mild or they have missed the area. So sometimes they just don't biopsy the right area, especially in mild cases. It can be quite tricky. When they put the scope down there, it looks a little red and angry. but it's mild, and they grade it. They have their own grading system, and they biopsy. They may not have taken a representative biopsy. So just because the histology is normal doesn't mean they're wrong. So you can either say in the sections taken or in the tissues sampled, there's no evidence, but it doesn't exclude esophagitis. Okay. If you're looking purely at the squamous epithelium, basal hyperplasia and the papillary elongation above normal are probably the most consistent features that you should use in trying to say whether it's reflux esophagitis if you don't have the history and you don't have too many neutrophils in the subtle forms. Okay, and as I said, if you have over 15 eosinophils per high power field, another diagnosis comes into consideration. Okay, and here's an example of reflux esophagitis. If you look, the epithelium looks a little bit bulkier and not as well organized as what I showed you as the normal. You'll notice also the nuclei right at the top are not as flat and inert looking as they were, but clearly the picture here is of basal cell hyperplasia. You can see it extending well beyond the single layer that is normal. The nuclei that were at the base now appear to be much, much higher, and that constitutes basal cell hyperplasia. In between, we've got eosinophils, and we've got neutrophils, and we've got this edema between the cells. So not only do we have basal cell hyperplasia, we have elongation of the papillae, and all of those add up to consistent with reflux esophagitis. Okay, just before I leave, in the instance where you also have, with the squamous epithelium, gastric type mucosa, then you've got to mention that clearly it may be the normal OG junction, or in fact it may be Barrett's esophagus. So that's also important to remember when you are confronted with a biopsy for reflux esophagitis. So if you've got intestinal or gastric type mucosa there, you have to either consider it being as normal or abnormal, and that again is dependent on the height at which the biopsy is taken, just as a reminder, but we'll come back to Barrett's in a minute. So I've alluded to eosinophilic esophagitis. This is becoming more and more evident because it has a very characteristic, as you can see, endoscopic appearance. You have these circumferential rings, very diagnostic, and it has what is known as a silvery appearance to the endoscopist. This is diagnostic in its own right, this endoscopy, and they biopsy it, obviously, because we are the ultimate determinants of any disease. And what it is a chronic immune-mediated esophageal disease, which is eosinophil laden, and it is associated in the vast majority of cases with a patient who has an allergic atopic background. And that history really is a clincher. So if you've got 15, 16, or even just less than the cutoff of 15 eosinophils per high power field, and the endoscopist has not told you they've seen these circumferential diagnostic rings, and there's a paucity of information. If you go into the history and see the patient also has allergic rhinitis and other allergic diseases, you can then go ahead and make the diagnosis of eosinophilic esophagitis off that information. 15 or more eosinophils per high power field in at least one of the biopsies, okay? As a result of the eosinophilia, you will get esophageal mucosal dysfunction, dysphagia, food impaction, and clearly you need to exclude gastroesophageal reflux disease, which hasn't responded to medical treatment in the form of proton pump inhibitors, because remember, they too can have eosinophils. And if they've been treated with drugs, that increases the propensity for eosinophils to be noted. So history is really important here. So diagnostic features when confronted with a biopsy, considering eosinophilic esophagitis, it's 15 or more. And usually you start counting in the superficial layers. So don't worry so much about the deep. If you count in the most superficial areas for the maximal count. So remember, it will vary. So you got to hunt around and do the count in multiple places, but your best hunting ground is in the superficial areas of the squamous mucosa. And in severe cases, you will start to see eosinophilic microabscesses. And because it's an inflammatory process, the basal layer will always react. Okay, and when you get a lot of eosinophilia, like you get in Churg-Strauss and other eosinophilic entities, you get these extracellular granules, flame cells, as is flame bodies. Again, because it's a reactive process, the gastrointestinal tract, the esophagus being no exception, has a very limited repertoire of responses to any injurious agent, be it drugs, be it inflammation, be it ischemia, be it any toxin. There's a limited repertoire, and so therefore you will also see papillary elongation in this and fibrosis, etc. The striking feature is that you don't generally get neutrophils in a pure example of eosinophilic esophagitis, so therefore that's another clue moving you away from reflux disease. Okay, so as I said, report the maximal count. So whilst it may vary and you get 17 in one area and you get 20 in another, just quote the highest that you see and then make the diagnosis. Again, multiple biopsies are essential to ensure that you get the diagnosis. Okay, and here's an example, very similar to the picture I showed in reflux, except here that you've got teeming numbers of eosinophils. And even on this picture, you can see the preponderance of eosinophils is in the superficial layer. So if you start counting here, for instance, you may not hit the threshold, but here's where the money is. So look around and look for the area that is most replete with eosinophils. Okay, so other common types of inflammatory conditions you will see, and biopsies are taken for it, although again, endoscopically, they're somewhat diagnostic, is Candida esophagitis, immunocompromised patients, patients on antibiotics, diabetics who are also immunocompromised, are predisposed to getting Candida esophagitis. And so I'll show you a demonstration of this. I would recommend that you do a pus stain. And sometimes a pus stain comes routinely with the GI set. So in a esophagus biopsy, you get a pus and a pus D that come routinely. In some institutions, they do not do any special stains. But I would always recommend, if you're considering Candida, do a pus stain, and you will be surprised at the number of organisms you will see on the pus stain as compared to on the standard H&E. Okay. One of the critical clues, and I've termed this the sandwich sign that you'll see, is where the neutrophils are. And I'll demonstrate that in a minute. Now, you know that Candida is often a commensal and can proliferate normally in an immunocompromised patient just sitting there because there's no defense mechanism and is non-infiltrative and really doesn't elicit an inflammatory response. So that would be regarded as a commensal or just as a innocent bystander. If you see the organisms beginning to elicit an inflammatory response and or start to penetrate the tissue, then it's a true infection. So just not surface colonization. So just be aware of that. Okay, so this is an example of Candida esophagitis. You've got this is a low power, a very good biopsy, as you can see. Nice mucosa, nice lamina propria, and then slivers of the lamina propria, looking a little thicker purely because of obliquity of section. But here's a lot of action going on the surface. It's a lot of inflammatory cells. The mucosa is reacting. You're getting these dilated, congested vessels, again, a bit obliquely cut, but you can see there's hyperplasia of the papillae. Basal cells are reacting. And if you look particularly here, you will see that the neutrophils, and I'll show it again under high power, but you can appreciate the sandwich sign better, is sandwiched between the mucosa and then the superficial layers of dead cells. So you've got the two slices of bread, one the mucosa and two the epithelium here, and sloughed off epithelium and dead cells, and the meat in the sandwich, of course, being your inflammatory cells, often with Candida organisms. And here it is under higher magnification. So you've got residual dying and some viable surface here. You've got the residual mucosa here, and in between, you've got the acute inflammatory exudate. And if you look carefully, you'll start to see the Candida organisms actually penetrating the surface. So whilst it's not invasive in an aggressive fashion and into the submucosa and vascular invasion like mucormycosis or aspergillosis, it is invading the superficial tissue and causing an esophagitis, as you can see quite clearly here. And the organisms are here. And H&E, you can see them very well. So they're made up of hyphae or pseudohyphae and spores as well. But if I did, and I unfortunately didn't take a photograph of the pus, actually there's a ton more of the organisms than are evident on the stain. And here it is here. So I'm showing you the pseudohyphae. So remember, it's an imperfect fungus, and then you've got the spores, but you'll see this sort of tangle of organisms. They're much smaller than aspergillosis. You can see they are septi here as well, but nothing quite like this. You've got these conidiophores within the sort of hyphal forms. Very characteristic, often seen coincidentally. And this is the second type of pathology that you should look for. Patient's got reflux disease, check if they've got coexistent candida. Here's just higher magnification. Again, this is an H&E stain, particularly florid. And you'll notice that you've got some bacteria contaminating the background as well. So just be aware of that and not to confuse those organisms. Herpes, another very common infection, very characteristic. Once you see it, you'll never forget it, very easy to diagnose. And why do we miss it? It's because of where it's located, and I'll show you that in a minute, okay? So you get intranuclear inclusions, which shapes the nuclei because they take over the DNA replication of the cell, and it pushes the resident chromatin out to the periphery of the nuclear envelope, the so-called margination. They call Cowdrey A inclusions as opposed to Cowdrey B, and they impart a ground glass appearance to the nuclei. There's very good immuno for herpes routinely. And the reason we miss it is because in and amongst the biopsy material, you'll get necrotic debris, inflammatory debris, bit of muscle there. And then with this biopsy, you will get normal intact mucosa. And again, we just get drawn to the normal areas or the obvious pathology. We say, oh, that's ulceration, inflammation, they've queried. Gastrointestinal reflux disease, gastroesophageal reflux disease, I'll make that diagnosis. There's ulceration there because of the reflux, not look. But that's why you need to look in the debris. And so to pick up infections, you must look in necrotic material. Amoebiasis is a classic example of you have this dead necrotic looking tissue not worth your attention, but you go in there and look for amoebae because you'll find them. Similarly here, we've got residual sloughed off squamous epithelial cells that have got these very typical inclusions within their nuclei. They're often multinucleated and have this steely blue appearance. And here they are, Cowdrey type A inclusions typical of herpes. If it's subtle and you're considering it, it's not diagnostic, do the immunohistochemistry. Okay, cytomegalovirus is another viral infection that's quite commonly seen, especially in immunocompromised, and gives rise to these characteristic owl's eye appearance. Again, it's another intranuclear inclusion related to the herpes family as well, but gives rise to this very typical owl's eye. You could imagine that on the head of an owl. Okay, so very nicely seen. CMV are located in 3 compartments, 1 in the surface epithelium, 2 in the stroma, as these are, and 3, you can find them in vessels. Epithelial CMV inclusions are really restricted to neonates and infants. I've not seen it in an adult other than a very, very severely AIDS compromised adult. So you will always find them in the stroma or in inflammatory cells, and here they are again. So again, a diagnostic pitfall here is that when you have a lot of inflammation and granulation tissue, endothelial cells can become prominent and hobnailed appearing as well with big nuclei. So just be careful, don't overcall. Again, if you have sufficient evidence and you're really concerned, do the immunohistochemistry. Okay, so I just want to start to accelerate a little bit. Barrett's esophagus, I've alluded to this already. There is a difference in the diagnostic criteria between what we use in Europe and the UK as opposed to North America. In Canada and the US, it's easy for us because If you see intestinal metaplasia, it's Barrett's esophagus, very simply by definition. However, in the UK, there are different guidelines. You call it squamo-columnar epithelium or mucosa with intestinal metaplasia, and it's very much dependent on where the biopsy comes from. And they have various phrases that are associated with it. So very different criteria. And that's why it's critical to have a very good relationship with the endoscopist. And so what is it? Quintessentially, it is a replacement of the normal squamous mucosa, which we've been demonstrating so far, by metaplastic columnar mucosa. So now you have replacement because of reflux. The stratified squamous epithelium undergoes metaplasia to columnar. And this is a little unusual because generally when you have metaplasia, it goes from a well-differentiated epithelium to a less well-differentiated. And squamous is regarded as less well. But in this particular case, it's a little bit paradoxical. It goes in the opposite direction. And once you start to get goblet cells, the defining feature of intestinal metaplasia, you have to start to consider diagnosis of Barrett's. And this is a very important diagnosis because it is a precursor lesion for esophageal adenocarcinoma. Now, not all cases of Barrett's progress. Not all cases of Barrett's with low-grade dysplasia progress. Not all cases of Barrett's with high-grade dysplasia progress. But there is a proportion of patients who go on. And therefore, the treatment is to break that cycle because we don't know who will go on to adenocarcinoma. Okay. The endoscopic criterion to make the diagnosis when the scope goes down is that the columnar epithelium extends above the gastroesophageal junction, and the minimum is a centimeter. So they will know, they will see the reflux changes, and they will biopsy it because it looks different. They often use sprays to identify columnar mucosa within the squamous mucosa in the esophagus. And as I said, when we see these specialized goblet cells, we then render that diagnosis. Okay, I've alluded to goblet cells. So instead of having gastric type mucin, they will have intestinal type mucin, and the stain to use there is an Alcyon blue at a particular pH, and that helps you distinguish between a gastric mucin, which appears red, whilst intestinal mucin appears blue. And these are within the columnar cells. You often find Paneth cells, endocrine cells, etc., and the architecture is a bit different. Okay, so here's an example again from an esophagectomy specimen, and the only reason I did this is just to illustrate the point, is that you've got mucosa that looks just like the mucosa you'd get from the large bowel, and it's quite extensive, and it shouldn't be here. Just proximal to this and distal to this, there was squamous mucosa. So this is a patch of Barrett's mucosa, clearly with the intestinal metaplasia, as you can see there. Okay, so the most important service you can deliver as a pathologist in Barrett's esophagus is to exclude or make a diagnosis of dysplasia, because it has very important therapeutic and management repercussions on the patient. Okay, so you need to report one of these 5 categories that are present. The statement is negative for dysplasia, and there was a consensus meeting amongst GI pathologists where we all agreed that no dysplasia or dysplasia is not seen, or words to that effect, aren't really sufficient and can get lost because clinicians, as you all know, don't read the reports carefully enough. So therefore, the statement is negative for dysplasia, and use it consistently. The next category is indefinite, and this is where, well, it would qualify for dysplasia, but there are some mitigating factors like inflammation, or it doesn't quite reach the criteria. I don't want to delve too much into this because Barrett's esophagus is a talk on its own, but I just want to highlight this as we go through. Low-grade dysplasia, distinctive features. High-grade dysplasia, adenocarcinoma is a no-brainer. So if I just go back, when it's negative for dysplasia and when there's adenocarcinoma, there is no real discordance amongst pathologists. The kappa values are close to 1. But when you have indefinite for dysplasia, high-grade dysplasia, low-grade dysplasia, those sort of conflicts, the kappa values drop considerably. So have your criteria, stick to it. And when you're stuck, I'm a great believer in P53 in this context only. I believe it in other ones, but in the gastrointestinal tract and biopsy pathology interpretation, P53 can be your best friend. There are well-known architectural and cytological features that distinguish high grade and low grade. Again, I think that's for another talk, given the constraints on time that we have. And I just want to show you a picture again of a resection. You've got your Barrett's dysplasia here with low grade and high grade. So remember, they can coexist. The high grade is actually over here. And then you can see now it's gone from within the basement membrane to breaching the basement membrane, ergo carcinoma, gland forming, hence adenocarcinoma. And really, it's traversed the entire thickness of the wall of this esophagus. But it's arising out of the context of Barrett's with no dysplasia, Barrett's with low-grade dysplasia, Barrett's with high-grade dysplasia. The full spectrum is actually seen in this picture. Okay, there's obviously, I've highlighted there's a risk for cancer, and depending on what you say in the biopsy, if you say negative dysplasia, then the patient will be surveyed by endoscopy every 3 to 5 years, depending on where you are. If you diagnose low-grade dysplasia, then they'll either treat with a small resection, depending on the extent, or they'll put the patient on PPIs, but they will monitor more extensively. So again, a very important diagnosis to make. And if you diagnose high-grade dysplasia, I would make a recommendation that you get another pathologist to confirm it, because they'll do endoscopic eradication. And because now the surgeries are less traumatic, you do have a little bit of latitude, and they remove it, and it's not a major operation. In the past, if you diagnose high-grade dysplasia, they'd remove the whole esophagus. And the last thing you want is to have a whole esophagus appear on your desk where you've diagnosed high-grade dysplasia and you can't find it in the resection. So this is a very important diagnosis to make. Always get a colleague to confirm it and have a look as well. Okay, so that's in the context of Barrett's. You also get squamous dysplasia, which is a precursor to squamous cell carcinomas, which have a very, again, geographic predisposition in Asia, Africa, Iran, related to cigarette smoking, alcohol. Some people talk about molybdenum in the soil in these areas. There's a whole host of soft features. There are some genetic features and genetic components to squamous carcinoma, but assessing dysplasia before it goes to squamous carcinoma is important in biopsies that you get. It's either low grade or high grade, quite simple. Okay, esophageal adenocarcinoma, I mean, the vast majority occur in the context of Barrett's. So the patient has a strong history of Barrett's, but sometimes it skips. If you've got chronic gastroesophageal reflux disease and the patient doesn't get biopsied, they can just present ab initio as an esophageal adenocarcinoma, and there are other risk factors. Okay, I won't go into the specific pathology of the adenocarcinomas. Squamous carcinomas are like squamous carcinomas everywhere else. Same features, same histological patterns, the way they infiltrate, the histological characteristics are the same as a squamous carcinoma anywhere else. Just for completeness, again, not all biopsies are done for tumors or pre-malignant conditions. As I mentioned earlier on, almost every patient is on some sort of medication, and sometimes these these pills get stuck in the esophagus and set up a local response there, and they stick in the esophagus and they cause this very well-defined entity of pill esophagitis. People take various types of ingest various poisons, etc., either willfully or accidentally, and these can cause caustic injury. And then to wind up, whilst adenocarcinoma and squamous carcinoma account for the vast majority of cancers that you will see, there are other tumors that are well recognized that occur in the esophagus. You may have heard of a gastrointestinal stromal tumor, which occurs anywhere in the gastrointestinal tract, but obviously, again, most prevalent in the stomach. If you see a spindle cell tumor in the stomach, it is a gastrointestinal stromal tumor until proven otherwise. If you see a spindle cell tumor, especially in the lower esophagus, it'll probably be a leiomyoma. So GISTs are not that common in the esophagus, especially in the lower esophagus. Not that they don't occur, but if you're a betting person, a leiomyoma is probably where you'd put your money on. Other interesting sort of incidental tumors that you can encounter are granular cell tumor and a variety of others. Okay, so we're reaching the end. So for biopsies, I have a checklist. And if you follow the checklist, you won't miss anything. This is the most important thing, is to be very methodical and do the best job you can. Look for the tissue adequacy, look at the different types present, assess each one. Look for intestinal metaplasia, look for inflammation, what types of cells you have, the distribution, the severity. Count the eosinophils if they're there. And then dysplasia. Always be on the lookout for dysplasia, whether the clinician thinks about it or not. Okay, as I always say, a systematic approach to any biopsy, any pathology that you get is really important. So you start at the top, work your way down, look at the different components. Understand the normal anatomy, because in the esophagus, where the biopsy comes from will impact on the diagnosis. Remember the common conditions that you'll see and what esophageal biopsies are taken from. And if you know those well, you will account for at least 90% of what you will see. But always think outside of the box. Think about dual pathologies, triple pathologies, okay? Dysplasia evaluation, this is probably the most important aspect of what you do with an esophageal biopsy. So have your criteria, stick to it, use P53 if you're wondering about high-grade dysplasia. If it's really mutant and very dark staining, it's high-grade dysplasia. And if you're in doubt, even if you think it's negative and you are worried, or you think it's indefinite, show it to somebody. Send it as a consult. The most cases I get in consultation is to exclude dysplasia in Barrett's esophagus. It's also very important to have clinical correlation. I can't really underscore this. You should develop a really good relationship with the endoscopist and the gastroenterologist. It benefits you both, and ultimately the patient gets the benefit of this communication. And I put in enjoy the experience. You know, I love looking at pathology. I mean, I've been doing it for many years, but I still get joy out of diagnosing even a routine Barrett's esophagus. So whatever it is, be enthusiastic, enjoy it, soak it up. It's not drudgery. This is a vocation, and be passionate about it. Enjoy the experience of the material that you get when you are evaluating it microscopically. Okay. As I said, we have a host of other educational events. Our sort of jewel in the crown is our annual Diagnexia Histopathology Symposium. It's in August this year, 2021, at the Queen's College in Oxford. It's always in Oxford. We've just changed colleges. I'll leave the QR code there for anyone to scan. It's on the website as well. So with that, I'll stop, I think, Mona, and I'm happy to take any questions.
Thank you very much, Runjan, for a great lecture. And you've actually set the roadmap for the correct approach to any type of biopsy, which is the systematic approach, and really sticking to that and reviewing the anatomy and the layers of histology as you go along regularly, and not be captivated by a lesion that would sort of make you miss the forest for the tree, as they say. And as always, your passion for the work and for the teaching, it was palpable from beginning to finish. So thank you so much.
No, my pleasure.
There are a couple of questions. You did mention the pill esophagitis, and someone, the attendants, was asking about impaction of food. Does it food impaction, does it cause eosinophilic esophagitis, or is it the result, or is it the cause of the result?
No, it's a consequence of the eosinophilic esophagitis, the narrowing. You saw the rings, those concentric rings. They cause narrowing, and it's a post-inflammatory reaction with scarring and fibrous tissue, and the food just impacts on it. So it's a secondary. So food impaction is secondary. Pill esophagitis is a primary event of its own. Anyone can get it. You don't have to have pre-existing disease. And the pill just sits there and gets stuck. I think we've all had that experience of a pill getting stuck, and we just drink copious amounts of water to move it down, right? But sometimes it just gets stuck and can't move, and that's where it starts to set up this local ulceration.
Okay. Someone was asking about the difficulty of differentiating low-grade dysplasia versus basal cell hyperplasia or basal layer hyperplasia, which I'm sure is an everyday problem. But do you have any tips to sort of...
Sure. Again, the clinical context is important. So if you know the patient has got gastroesophageal reflux, so then there's every reason for the basal layer to be reactive, and you'll have an accompaniment of inflammatory cells. So if you have elongation of the papillae, edema, inflammatory cells, would the history and the basal cells look a bit jumbled up and there's hyperchromasia and a few mitoses, report it in that context. I personally never call dysplasia in the presence of inflammation. You will always, you can get it horribly wrong. So generally speaking, if you then think, this is a bit more than basal cell hyperplasia, but you've got inflammation and edema, etc., then you say, well, rebiopsy. Let the inflammation settle, treat, rebiopsy. If it truly is dysplasia, it'll remain despite the treatment. In the absence of inflammation, edema, and any other cause for the basal layer to be angry, I will call dysplasia. Okay, so you will see mitoses. Again, you'll see the loss of the normal single layer. And if there's no inflammation, then it's dysplasia. High-grade dysplasia or full-thickness dysplasia or carcinoma in situ is obvious.
Thank you. You mentioned the value of P53 in evaluation of dysplasia. How do you interpret that? I'm sure you're aware in gynae we've got criteria for mutants.
Absolutely, that's why I said in GI pathology we use it mainly in this context. So when you stain, P53 is a normal protein. It occurs in the cell cycle, and so therefore you will get wild type expression when you do the immunohistochemistry. And the wild type expression is usually light brown, it's nuclear, it's usually restricted to the basal layer, okay? And you'll see it, despite what the H&E appears that you've got some thickening of the basal layer, hyperchromasia above the base. When you do the P53, it'll actually only pick out the very basal layer if it is reactive or if it's hyperplastic. So that would be mutant expression. But if it's very dark brown, and very much like, when we do HPV and P16, you have this block-like positivity. You know what I'm talking about, Mona, in the gynae tract. And it's very intense. Then that is mutant expression. And when I'm now wondering whether this is A-reactive or is it low-grade or is it high-grade, when I get very strong mutant, intense brown staining, it pushes me over to go to dysplasia. So that's how I use it. I have used it also in ulcerative colitis, similar sort of thing to Barrett's for dysplasia. But other than that, in the GI tract, we don't use P53, but it's very, very, very good in Barrett's dysplasia.
And on the note of immuno, someone was asking if you've got a biopsy with severe inflammation, but you're not seeing any viral cytopathic effects, would you still consider doing CMV immunostaining?
The only time I would do it if there's a strong clinical index, if they tell me the patient is immunocompromised, either from a transplant or HIV or some other compelling reason. In a normal non-immunocompromised patient, if you don't see it, it's not there. Immuno is not going to magically make the inclusions appear in that context. In the immunocompromised, you get what are known as atypical viral inclusions, and they don't look like the obvious owl's eye or the obvious, other inclusions, herpes, etc. They can be quite subtle, and they're called atypical. In that context, if your index of suspicion is high, you've got inflammation, you've got something that sort of makes you concerned, do the immuno. The benefit of your doubt should go to the patient.
Thank you. You mentioned the importance of correlation with clinical information, particularly the level from which the biopsy was taken. And someone is asking if you can differentiate intestinal metaplasia from cardia just on histological grounds.
No, unfortunately not. Intestinal metaplasia is intestinal metaplasia no matter where it is. So if it's cardiac mucus, say they've gone down to 27 centimeters and I've not told you, biopsying the true cardia, which happens to have intestinal metaplasia, then I will say it is gastric type mucosa showing intestinal metaplasia. However, if they haven't mentioned the level, then I'll say, well, this is dependent on where the biopsy is from. If it's from below the OG junction, then it's cardiac or gastric cardia intestinal metaplasia. If it's above, consider Barrett's esophagus.
Thank you. And one last question about pill esophagitis. Someone is asking, in the absence of history, is there a way of diagnosing pill esophagitis?
Yeah, and it usually gets stuck in the sort of upper middle third of the esophagus. It rarely goes beyond that. So if you've got a focal area of ulceration, very nicely demarcated in the upper mid esophagus, you may see remnants of the pill. You remember pills come in these carriers, and these carriers have got fibers in them. You can see remnants of that embedded within the inflammatory exudate. Yes, you can suggest it.
Runjan, thank you so much. It only remains to convey to you the great appreciation of all the attendants who've expressed it in the chat box for a great talk. And thanks again for supporting the whole initiative. And I invite everyone to keep their eye out on the Diagnexia web pages and on the Facebook page and website of the Egyptian Committee for Pathology Training to catch the announcement of the forthcoming webinars. And we look forward to seeing you all again here. And do stay in touch and let us know if there are certain topics that you would be very keen to or interested in having webinars on, and we'll work together on delivering that. Thank you all very much for being here, and thanks a lot, Runjan, for
my pleasure.
Input.
And we hope to really make this a success, and we look forward to feedback. We've got some really good speakers lined up as well. So we really want this to work and have an impact on your education.